Starting in 2026, Medicare beneficiaries face a new reality with prescription drug costs, CAP, at $2,100 per year. But while this sounds like universal good news, the truth is far more complicated. Some people will save thousands, others will actually pay more than before, and the pharmaceutical industry is fighting this change with 12 active lawsuits across the country following the Third Circuit Court's May 2025 ruling that upheld the program. This cap represents the biggest overhaul of Medicare Part D in over a decade, stemming from the Inflation Reduction Act that President Biden signed in August 2022. For the first time in Medicare's history, there's a hard annual limit on what you'll pay out of pocket for covered prescription drugs. Once you hit that $2,100 threshold in true out-of-pocket costs, you won't pay another penny for covered medications for the rest of the year. But here's what makes this story fascinating and frustrating. This isn't just about a simple price cap, it's about winners and losers, hidden costs, and a massive reshuffling of who pays what in America's healthcare system, with pharmacy benefit managers, PBMs playing a crucial behind-the-scenes role in driving up costs for lower-spending beneficiaries. Let's start with the winners because their stories are genuinely life-changing. Take people with conditions like cancer, rheumatoid arthritis, or diabetes who rely on high-cost medications. Before these changes, some Medicare beneficiaries were spending $10,000, $15,000, even $20,000 a year just on prescription drugs. People with cystic fibrosis who reached the catastrophic coverage phase were paying an average of nearly $9,500 for their Part D covered drugs in 2022 alone. The most immediate winners are the nearly 9 million Medicare beneficiaries who use the 10 drugs that underwent the first round of government maximum fair price negotiations through the Centers for Medicare and Medicaid Services. These medications treat everything from blood clots to diabetes to autoimmune diseases, and their negotiated maximum fair prices will save users a collective $1.5 billion in out-of-pocket expenses in 2026. Consider Januvia, a diabetes medication. A 30-day supply will cost $113 in 2026, down a staggering 79% from the 2023 list price of $527. For Eliquis, which prevents blood clots, the maximum fair price drops 56% from $521 to $231 for a 30-day supply. These aren't small adjustments, they're dramatic reductions that will fundamentally change what people pay for life-sustaining medications. The 10 negotiated drugs include household names like Eliquis for blood clot prevention, Enbrel for rheumatoid arthritis, Jardiance for diabetes and heart failure, and various insulin products. These medications were selected because they represent some of the highest spending in Medicare Part D. Together, they account for $50.5 billion in total Part D costs, or about 20% of all Part D spending during the measurement period. Another major victory continues from 2023, the $35 monthly cap on insulin for Medicare beneficiaries. This applies to both Part D and Part B insulin coverage, with no deductible required and no Part D late enrollment penalty implications. For diabetics who are rationing insulin due to cost, this change has been genuinely life-saving and remains a cornerstone benefit heading into 2026. But here's where the story gets complicated, and where AARP's strong support for these reforms meets an uncomfortable economic reality. While some people are celebrating massive savings, research from the USC Schaeffer Center reveals an uncomfortable truth. Most Medicare beneficiaries will likely see their drug costs go up, not down. Erin Trish, co-director of the Schaeffer Center, puts it bluntly: the new annual cap will provide valuable relief to the small share of beneficiaries with the highest drug spending. But our research shows this comes with a clear trade-off. Most Medicare beneficiaries will likely see their drug costs go up. How is this possible? The answer lies in how Medicare Part D plans and pharmacy benefit managers are adapting to the new rules. When the government capped out-of-pocket spending, it shifted more financial responsibility onto the insurance plans themselves. To compensate, these plans are changing their structure in ways that hit lower-spending beneficiaries harder. One major change is the shift from co-pays to co-insurance, heavily influenced by PBM cost management strategies. In 2024, only 2.6% of Medicare Advantage drug plan enrollment required co-insurance rather than fixed co-pays for common brand-name drugs. By 2025, that number skyrocketed to 27.5%. For standalone drug plans, the shift is even more dramatic. 84.1% of enrollment now requires coinsurance, compared to just 9.9% in 2020. Why does this matter? With a copay, you might pay $45 for a medication regardless of its list price. With coinsurance, you pay a percentage, say 25% of the drug's cost. As drug prices rise, your coinsurance payments rise too. This means that even with the annual cap in place, you could be paying more month to month for the same medications. Deductibles are also rising sharply. Average annual deductibles in Medicare Advantage drug plans nearly quadrupled from $62 to $224 between 2024 and 2025. This was driven by a steep decrease in more generous plans with zero deductibles, which fell from 78% to 41% of enrollment. The national base beneficiary premium for 2026 is set at $38.99, reflecting these structural changes. The math is stark. Of the 65 million Medicare beneficiaries, only about 5.6 million actually benefit from these changes. That's roughly 1 in 12 people. For everyone else, the new system may actually cost them more. Low-income beneficiaries face their own set of challenges. If you qualify for the low-income subsidy through Medicare's Extra Help program, your plan options are shrinking. The number of benchmark plans, the ones available at no extra cost, will drop slightly from 90 in 2025 to 88 in 2026. This continues an alarming trend. In 2023, before the Inflation Reduction Act, there were 191 low-income subsidy plan options. For beneficiaries struggling with these higher upfront costs, the Medicare Prescription Payment Plan, M3P, offers some relief. This program lets beneficiaries spread their annual drug costs into monthly payments rather than paying large lump sums at the pharmacy. This doesn't reduce costs, but it can make budgeting more manageable for people on fixed incomes. There's also critical fine print that many people miss. The $2,100 cap only applies to drugs covered under your Part D plan's formulary. It doesn't cover drugs administered in a doctor's office or hospital, which fall under Medicare Part B. It doesn't cover your monthly premiums. And if your plan doesn't cover a particular medication, if it's not on their approved list, those costs don't count toward your TROOP spending at all. This creates a perverse incentive for plans to drop expensive medications from their formularies entirely, potentially forcing patients to pay full price for drugs they need or find alternatives that may not work as well. If you need help navigating these complex choices, your State Health Insurance Assistance Program SHIP provides free, unbiased counseling to help you understand your options and find the best plan for your specific medications. The pharmaceutical industry isn't taking these changes lying down. Companies have filed 12 separate lawsuits across the country, arguing that the Medicare Drug Price Negotiation Program violates the Constitution. Following the Third Circuit Court's May 2025 ruling that upheld the program, most have been unsuccessful, but the legal battle continues. Bristol Myers Squibb, maker of Eliquis, captured the industry's frustration in a statement to NBC News. "We have no choice. If we did not sign, we'd be required to pay impossibly high penalties unless we withdraw all of our medicines from Medicare and Medicaid. That is not a real choice, and we would never do that to patients." The penalties are indeed severe, more than $500 million for refusing to negotiate. Merck argues on its website that beyond constitutional concerns, this program will negatively impact biopharmaceutical innovation and the sector's work to develop life-saving and life-changing innovations. But there's another layer to consider. Some experts worry that increased utilization management requirements, prior authorizations, step therapy, quantity limits could actually reduce patient access to medications, exactly the opposite of what the program intends to achieve. The timeline for these changes spans several years, with major developments ahead. The $2,000 cap took effect in January 2025, eliminating the infamous Medicare donut hole coverage gap. The $2,100 cap and first negotiated maximum fair prices begin in January 2026. By 2027, negotiated prices for 15 additional drugs will take effect, including blockbuster GLP-1 medications like Ozempic, Wegovy, and Rybelsus for diabetes and weight loss, potentially saving another $8.5 to $12 billion annually. The program will continue expanding, with up to 15 more drugs in 2028 and up to 20 drugs selected each year thereafter. The inclusion of GLP-1 receptor agonists in 2027 negotiations is particularly significant, as these medications often exceed $1,000 per month and have become essential treatments for both diabetes, mellitus management, and weight loss. Looking at 2026 specifically, there are some positive developments. The average standalone Part D plan premium is projected to decrease from $38.31 in 2025 to $34.50 in 2026. The government's premium stabilization program, while scaled back, will continue providing some financial support to plans. However, the fundamental tension remains. Stacy Dusitzina, a health policy professor at Vanderbilt University Medical Center, explains, before that law passed, people would spend $10,000 or $15,000 out of pocket each year just for a single drug. The Inflation Reduction Act was necessary to make Part D proper health insurance, but there's a cost to do so. The cost is being borne by the broader Medicare population through higher premiums, deductibles, and shifting cost-sharing structures influenced by pharmacy benefit manager negotiations with plan sponsors. It's a classic example of health policy trade-offs, helping those with the highest costs while potentially raising costs for everyone else. Despite these challenges, the negotiated maximum fair prices represent a historic shift. For the first time since Medicare Part D launched in 2006, the federal government is directly negotiating prescription drug prices. The Congressional Budget Office estimates this will save Medicare $98.5 billion over 10 years, with much of those savings flowing to beneficiaries with high drug costs. Recent developments add another wrinkle. In November 2025, the White House announced that manufacturers of popular GLP-1 medications like Ozempic and Wegovy, Eli Lilly and Novo Nordisk will lower prices when these drugs are purchased through Medicare. These medications used for diabetes and weight loss have become blockbusters with list prices often exceeding $1,000 per month. As we look toward the future, the success of this program will likely be measured not just in dollars saved, but in access maintained. The real test will be whether the benefits for high-cost drug users outweigh the increased costs for the majority of Medicare beneficiaries, and whether patients can still access the medications they need as plans adapt their formularies and cost-sharing structures. The $2,100 cap represents a fundamental philosophical shift in Medicare Part D, from a program that left some beneficiaries exposed to unlimited prescription drug costs to one that provides genuine insurance protection for catastrophic expenses. But like most healthcare policy changes, it comes with trade-offs that affect different groups in different ways. For the 9 million people using the first round of negotiated drugs, and for anyone facing truly catastrophic prescription costs, this change is transformational. For the majority of Medicare beneficiaries with moderate drug spending, the new reality may be higher costs and fewer plan options. Understanding these nuances is crucial for anyone navigating Medicare in 2026 and beyond. Remember, if you're feeling overwhelmed by these changes, your state health insurance assistance program provides free, expert guidance to help you navigate Medicare Part D options and understand how the maximum fair price negotiations might affect your specific situation. The story of Medicare's drug price reforms is ultimately about choices, who we help, how we help them, and who pays for that help. As this program continues to evolve over the coming years, those choices will shape prescription drug access for millions of American seniors for decades to come.